dear colleagues, and dear students. I think there is a little overlap between my talk and that of the subsequent one by Professor Vijay Lakshmi, because she will also be talking on the pediatric cath lab intervention in pediatric cardiology. What I shall try to do is straight away go to some charts which is being given in the examination for interpretation. This is given in the sports as well as during the Viva. I want some of the students, I told them earlier, to help me interpret these things. This is the normal oxygen saturation and the pressure data. It is, you can find it everywhere. Let us start with the first one. I will ask you guys to interpret. A 18-year-old asymptomatic, acyanotic, S2 white split, and there is an ejection systolic murmur at the base. What is the diagnosis? One of you, please, quick. I help you. There is a oxygen step up at right atrial level, which is maintained. Left-sided saturations are all right. Rest you, now you tell the diagnosis.
ASD.
This looks like an ASD, but for ASD you need to look at the pressures. What is the right atrial pressure? It is 5. What is the left atrial pressure? It is the wedge pressure is 10. Can it be an ASD? In ASD, there will be an pressure will be same in both right and the left atrium. It is not so. Second point, right atrial pressure has not gone up. If it received the blood from some high pressure chambers like, say, a left ventricle or RSOV, right atrial pressure will go up. It has also not gone up. So, diagnosis is a simple PAPVT. This one. It is extremely simple chart. Please. One of you. Yes, yes, please. You take a mic.
TAPVC, sir.
TAPVC. Will you a little specify it or further clarify?
Sir, supracardiac TAPVC.
It is?
Supracardiac TAPVC.
Excellent. It is a supracardiac TAPVC. It is TAPVC because all the cardiac chambers are having a similar saturation. So PA and systemic saturations are same. It's an admixture physiology. Look at the SVC. SVC is also high. Saturation is also high. So it is a supracardiac TAPVC. Excellent. This one, this looks very simple. Come on. Sorry? ওহো এখানে তো চলে এসছে এই দুটোই চলে এসছে ঠিক আছে ওকে Come on, man. My time will be over and I have to leave. What is there? There is a right-sided saturations are lowish. What is the pressure of the right ventricle? 120. Pulmonary artery couldn't be entered. We don't have any data. So, there is a pulmonary stenosis and there is a systemic desaturation. Femoral artery 65. So, there is a right to left shunt. Right to left shunt, most likely we are dealing with a case of an TOF. But what is the difference? Is it a classical TOF or something else?
Sir, TGA VSDPS.
Yes, 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 please.
Sir, TGA VSDPS. Top physiology.
TGA, VSD, PS. No, for TGA you need to know the pulmonary artery saturation. I will come to that. Here,
Sir, it can be a case of pulmonary atresia with VSD.
this is top physiology I am talking about. This can be, but there is a difference. Look at the left ventricular pressure. Left ventricular pressure is 90. RV pressure is 120. That being so, so the VSD, the right ventricular pressure has gone suprasystemic. In TOF, that is not the case. Pressures are almost equal. In which situation the RV pressure will go suprasystemic?
Where the VSD becomes restricted.
If the VSD becomes
So
restrictive,
Hoffman
madam, it is for them. So, if the VSD becomes restrictive, you know how the VSD can be restrictive in a case of fallow. The prototype, you say an accessory tricuspid valve tissue. Got the point? This is a TOF with a restrictive VSD. This one. First see the oximetry. Yes? TGA. Be a little more specific. TGA is part of the answer. Good. Why do you say it's TGA? Give him a mic, man.
So pulmonary saturation is more than aortic saturation.
More than?
Aortic saturation.
Very good. That straight away points towards a transposition physiology. Aorta more than, a pulmonary artery more than aortic saturation. Look little more in detail. There should be some admixture somewhere in a TGA physiology. Where it is at? See, what is the
So there is tape up and
LV is giving rise to pulmonary artery. LV pressure is 42. RV is giving rise to aorta. RV pressure is 95. So, intact interventricular septum. Then, see the right atrial pressure, it is 6. Left atrial pressure, it is 5. So, admixture must be taking at that point. So, this is a case of transposition with intact ventricular septum and an ASD. That becomes the complete answer. This is interesting. A 16-year-old with a large VSD, severe PAH. Question is whether, ওখানে একটা mic রাখো না, whether this patient is operable. The initial CAT study showed on oximetry side, right ventricle is 80. And on the left side, there is a desaturation there, suggesting a bidirectional shunt. Look at the PA pressure. It is 116/70. Mean is 88. So these are the patients. Before condemning them, you should do a reversibility test. How that is done? Give 100% oxygen for 10 minutes and do a second study. Second series shows PA saturation has gone up to 88. PA flow has improved. And what most important thing you should look at is the pulmonary artery diastolic pressure. It is 50. It was 70. It is 50. So there is a fall in the PVR. Okay. Now see, in the room air, QP was 4.5, QS was 3, QPQS 1.5, PVR was 15.8, whooping, and PVR SVR was 0.6. But after giving oxygen, see the QP has gone up to 10.7, QPQ and QS remains almost same, QPQS 3.2. PVR has come down to 6.4 and the ratio is 0.22. This patient is likely to derive benefit from surgery, though it won't be normal, but is likely to derive benefit from surgery. Interesting case. One of you, please respond. Right-sided saturations are all right. PV is 95 from LA. That is a desaturation. Pressures are normal everywhere. Diagnosis, no clinical input is there. Yes, please.
Pulmonary AV fistula.
That is perhaps the first answer, but I said no clinical input. If had there been a continuous murmur, definitely I would have gone for that. Yes? In that case, there will be some desaturation on the left side. Isn't it? Here there is a desaturation in LA. Anything else, there is no other evidence of any flow on the right side. That is a form of an ASD. That is one cause of desaturation at LA level, agreed. But in this particular setting, the commonest is a pulmonary AV fistula, followed by, these are the causes of pulmonary PV desaturation. See, if you probe a pulmonary vein, if that is a part of the AV fistula, that saturation will be low. But if you enter the other pulmonary veins, this will be normal. So you cannot be very sure whether what is the status of the pulmonary vein. So we take it from the left atrium downwards. So desaturation at the LA level is that you have many causes. Epstein's, a tricuspid atresia, unroofed coronary sinus, large ASD, or rather a common atrium. RPA LA fistula is a rare but entity where you don't get any clinical signs, but LA is desaturated. IVC is streaming across the ASD. You know, all of you know about that. And IVC, or a systemic vein connecting with the left atrium, that remains another issue. What is this case? Almost a similar case we have discussed earlier. A desaturation in the slight desaturation on the right side as well, suggesting the cardiac reserve is very low here. And that is systemic desaturation. RV pressure is 120, PA could not be entered, so there is a severe pulmonary stenosis or atresia, whatever it is. So this is a tetralogy, physiology. See the right ventricular and the right atrial pressure, a right ventricular and the left ventricular pressure, they are similar. A 9-month-old boy with a continuous murmur. Quick. PA is 78. So there must be some extra. Yeah, please. Can be an AP window? Huh? AP window. There is a right to left shunt, net right to left shunt. Aorta is desaturated. So a right to left shunt is there. Look at the pressures. RV pressure is 96. PA pressure is 20. So there is a pulmonary stenosis. Look also the LV pressure. It is similar to RV pressure. So there is a non-restrictive VSD. So it's a TOF physiology with either a PDA or a BT shunt if there is a history of a BT shunt. This exactly same thing is mentioned here. So ultimate diagnosis is it's a fallow with a PDA because there was no history of a BT shunt. This one, 35-day-old with increased precordial activity and duskiness. This is very easy. Whatever we discussed a little while back, same PA and aortas, same saturation, admixture physiology, cardiac chambers having a similar saturation, TAPVC, SVC is 66. So it's a cardiac type of TAPVC. That is the only difference. 12-year-old asymptomatic boy with incidentally detected continuous murmur. Now, you please respond. You lady. You have told it earlier.
Sir, unroofed.
Why you are biased towards an unroofed? Huh?
There's a, sir.
What is
step
there?
down and step
Incidentally
down
detected
and murmur.
continuous murmur. Don't forget that.
Okay.
There is a continuous murmur, asymptomatic totally, but there is a systemic desaturation.
Sir, AV fistula, pulmonary.
Pulmonary AV fistula. This is a classical of pulmonary AV fistula. So don't put in unroofed coronary sinus. Unroofed this coronary sinus in all cases. This one. A 23-year-old female with recent onset palpitation and dyspnea. This is an interesting case. Somebody from this table should respond. Anybody? RA is high. RA saturation is 86. Otherwise looks like an ASD. Is it an ASD? If yes, why? If no, why? Come on. No, it is not a Garbody's type of defect. Why? In Garbody's defect, aortic pressure will not be 140 by 40. This wide pulse pressure rules out a Garbody's type of defect. So, what else? No, sir. Look, RA saturation
Sir, this is
has
RSOV,
gone
sir.
up.
Sir, RSOV. To RSOV.
RSOV, RA pressure has gone up. So this is, and you have a widened pulse pressure. Everything is pointing towards an RSOV opening into right atrium. Okay. A 19-year-old known heart disease since childhood. Patient is asymptomatic. See the saturations carefully and tell me what is the answer. This, all of you will be able to tell, I am sure. Should I give some lead? আরে বলো সরি একজন বলো ওঠো দাঁড়াও সরি See, madam, SVC is 72, RA is 70, RV is 98, PA is 70. So they cannot be connected in series. It's not possible. Okay? Again, PA is 70, aorta is 96. That is no shunt lesion. These two things we have found out. See the left side. LA 99, LV is 70, aorta is 96. Straight away it is telling that there is a double discord.
CCTGA, sir.
CTGA. It is a, you see, RA is opening into LV, which is giving rise to aorta, giving rise to pulmonary artery, I'm sorry. So,
You should have written morphological, then they would have known the diagnosis.
see the LV pressure. LV pressure is 32, PA pressure is 20. So, they are concordant. It is going like that. Similarly, your right side, LA, is 99, opening into RV, 98, giving, and pressure is 100, giving rise to aorta, pressure is 100. So, it is a CTGA. CTGA at this age usually remains asymptomatic. They get symptoms after usually in the 4th decade onwards with heart failure and all, provided there is no intracardiac anomaly.
Thank you, sir.
This is what you guys do almost every day. Not every day, once, twice or thrice in a month. Very simple. Black side is one study, red side is another study. এটা না বলতে পারলে মুশকিল। First tell this side, left side. Take the mic and speak. Attempt it, man. Come on, get up.
Sir, pulmonary wedge pressure is decreased from 55 to 24.
Right.
LVEDP raised from 10
You
to 24.
first tell the left-sided study. This is only the pressure study, no oximetry.
Sir, PCWP is more, and there is a gradient between the ALA pressure and LV pressure.
So what is the diagnosis?
Mitral stenosis.
Very good. There is a tight mitral stenosis with pulmonary hypertension. Excellent. Now you have done a BMV. And the wedge pressure, which was 48, has come down to 20. And there is hardly any gradient. The PA pressure has also come down to 40 by 22. So this is the case of mitral stenosis, pre and post BMV.
So why the LVDP is raised?
It was a
LVDP
very tight,
24.
sometimes we have found this thing, with very tight mitral stenosis, suddenly if the blood gushes in, LV pressure, LV EDB transiently rises, then it settles. A similar sort of a thing we find in constrictive pericarditis as well. If the constriction is of long standing, patient goes into failure. But here there is no, yes, Shuvana.
That is also an indicator whether there is an MR. If you develop an MR, in
That
that
is,
case,
quite
the
true.
BY would have been more.
I was just going to tell that thing, but here there is no MR because V wave was 40 pre and it is 22 post. So there is no MR.
But sometimes rheumatic can produce myocarditis with fibrosis.
Sorry?
When rheumatic carditis, a pancarditis, sometimes some amount of myocardial damage could be there that can raise it.
Possible, but madam, earlier the pre-BMV pressure was 10, so I am ruling that thing out. One of you, this is again we are back to congenital. Yes, yes, please. Take the mic. Are on corner, Baba.
Hello.
Ah.
Sir, this appears to be a case of restrictive VSD because there is a difference in pressure between RV and LV, and also, sir, there is a gradient between RV and PS. So there is a VSD PS, sir.
It is a VSD PS with a persistent
With a
left to right shunt.
shunt, sir. Yes,
That
sir.
you need to
So
say.
every gasolization, sir. Gasolization maybe. VSD.
I won't comment on
Okay, sir,
that
yes, sir,
from
yes.
this
VSD
study
value,
only.
yes, okay.
I don't have the other data, but
Okay.
this is the case of a VSD with a persistent left to right shunt despite having a PS. So it doesn't mean that VSD PS means there is a right to left. If it is not severe enough, you can have a persistent left to right
That
shunt.
is pink fallow.
Yeah.
With the Gassol's effect.
This one. अरे बोलो भाई. Anybody? What is there? There is a step up at the right atrial level and looks like ASD. There is a left to right shunt. What else? Why it is there? Why it is so? Huh? There is some amount of pulmonary hypertension, agreed. But right atrial elevation most commonly is because of an ASD. Is it an ASD? No, why no? Exactly. LA pressure is 10, RV pressure has gone up to 14. And where is the lift in the right atrium? It is in the low RA. Low RA is having a 84. That means it can be a Garbodis, it can be a RSOV, it can be a Garbodis, but low RA Garbodis is more likely, and there is no widening of the pressure in the systemic artery. So this is a LV RA shunt. Good. Eta ki? There is an oxygen step up at the pulmonary artery level. Most commonly we find it with PDA. But with PDA we also expect a widening of the pulse pressure, which is not there. We can also find it with RSOV opening into a pulmonary artery. There also we expect a widening of the pulse pressure. Third option is if there is a subpulmonic VSD, and because of the streaming, pulmonary arterial saturation will be high. So these are the three alternatives, and my take is the last one. It is likely to be a subpulmonic VSD. Quick. Saturation wise, it looks normal. There is nothing wrong in it. See the pressure until the diagnosis. That is a systemic hypertension. Aortic pressure
It's
is
a coarctation.
Coarctation.
very good. It is a coarctation or some obstruction in the descending aorta. Very good. What is this? Quick. Look at the lower side of the panel. You get the answer. Aortic saturation is okay. Femoral artery saturation is 62. Pulmonary, look immediately at the pulmonary artery pressure. It is
PDA with reversal of
107.
shunt. PDA with reversal of shunt.
PDA Eisenmengers. And this is the last slide. It is very familiar. I have taken it from a textbook. This is Brockenborough, Braunwald, Morrow's sign. This is a classical pattern. One of you please say what is this? What happens? One of you, please.
So if there is a BPC, post-BPC, and we can differentiate the HOCM and AS. If after the BPC, the pulse pressure reduces, it's a patient of HOCM, sir.
After the VPC,
BPC, the pulse pressure reduces.
pulse pressure reduces. That is the clinical counterpart is you get a lower pulse.
Yes, sir.
Exactly, that is what is happening. Here is the VPC, and see the post-VPC. There is an increase in the gradient, but decrease in the pulse pressure. And it is because of more forceful contraction and more obstruction to the LV outflow tract. Thank you very much for your participation and patient hearing. Thank you very much.